As for retired Americans, strong support.
Thank you. Opposition?
Mr. Chair, members, Tim Madden, representing the California chapter of the American College of Emergency Physicians. We currently have an opposed position, but we do want to take a minute to thank the author, sponsor, and Senator Hernandez, your staff, in working with us on including an amendment that appears CNA is going to take that would exempt the emergency department. Unfortunately, I don't have an answer in terms of it changes our position. In quick conversations with our folks, there still remains some concerns. And as many of you know, in emergency departments, we do provide observation services. Many times they do last more than 24 hours. Depending on the hospital, some of those observation services might actually be performed not in the physical emergency department as the Department of Public Health would define. It may happen across the hallway in another location. It is still a patient of the emergency department. They're receiving observation services as an emergency department patient, but they're outside of that unit. Thus, they would still be subject potentially to the 24-hour limit. We've had a number of conversations with the sponsor to try and work through this. Not sure there's a pathway, but the sponsors have indicated they do want to continue to work with us, and we're going to definitely work with them moving forward. But at a minimum, just want to expand on our position and available to answer any questions.
Good afternoon, Mr. Chair and members. Connie Delgado with the California Hospital Association. Observation is a tool that physicians use to determine whether or not a patient should be admitted. And this bill would create some conflicts with the federal CMS regulations on observation. We also believe that patients should receive care based on their needs and not the name of the unit for which they are placed. We do recognize that staff has been working very diligently to address some of the concerns that we have. The issue of observation is very confusing, and for those reasons, we are opposed to this bill. I have Dr. Perot here with me to answer any technical questions that you may have.
Anyone else in opposition?
Bernadette Ariano on behalf of the California Children's Hospital Association. We appreciate the amendments, but we remain opposed. Thank you.
David Ford for Adventist Health and Loma Linda University Health in opposition to the bill.
Amber King with the Association of California Healthcare Districts, also in opposition.
Les Shepard representing Stanford Healthcare in opposition.
Tom Bone for Sutter Health. We're in opposition.
Thank you. Questions or comments? Yes, Senator Roth.
You know, one of my questions and concerns has to do with psychiatric, I use the word patients. At least in certain parts of inland Southern California, my recollection from service on hospital boards was that we have a shortage of psychiatric beds down there. My recollection from sitting on a particular hospital board that we received a patient probably into the emergency room that attempted suicide, had apparent psychiatric issues, and the hospital, we were unable to locate a psychiatric bed in a licensed facility to take care of the patient. And so the patient, unfortunately, sat in our acute care hospital for some period of time. So I guess my question is this: if the patient's not in the physical emergency room, and I don't remember exactly where the patient was, would there be problems with the 24-hour rule? How would that be handled? What complications does that present for hospitals that can't find, in the case of a psychiatric patient, or one that appears to have psychiatric issues? What problems does that pose, does this bill pose, if any?
Yeah, I also chaired a hospital board for 8 years, so yeah, we put together an amendment that we think helps ameliorate it. Won't probably want to ameliorate everybody's concern, but I think we did deal with that in the amendment that we worked out with the committee. Helps ameliorate that issue, and maybe have some people speak to that amendment. So, deals with your issue.
Mr. Chairman.
Could you answer that, or would you like to?
I'm asking my people to answer the question.
I will direct my question. Go ahead, answer, then I'll give it a response.
Yes, me.
I don't know if I was articulated. But my question has to do with psychiatric patients that present with apparent psychiatric issues to a acute care hospital that's not licensed as a psychiatric facility in an area where there's a shortage of mental health beds in licensed mental health facilities. So what happens to that situation where we're waiting for a bed to open up in a facility that's equipped to treat the patient, so the patient's held in the acute care facility, perhaps not in the emergency room because perhaps there's no room, but not necessarily as an inpatient, if that can possibly happen. So how does this bill impact that situation is my question.
Currently, as nurses, we see psych patients really on a daily basis because, as you said, we do have a lack of psychiatric care treatments throughout the state, and it has been that way since the 70s, shamefully so. But we cannot turn our back on these patients. So these patients must be admitted to an inpatient bed to receive treatment because we can care for them without being a designated psych unit. And we do care for them because many of the patients that we currently have some sort of psychiatric illness as well.
So it would be in the form of an admission
Sure.
to the hospital as opposed
Yes.
to an observation period?
Yes.
Mr. Chair.
Or a 72-hour hold. That's the other way.
Senator Roth, would you like him to ask a question?
That would be fine, Mr.
Okay,
Chair.
by all means, go ahead.
Thank you, Mr. Chair. Thank you, Senator Ralph. It would depend upon where they are placed. If they were placed into the observation unit because there is an assumption that they were going to be transferred to an inpatient psychiatric facility somewhere else, and then that transfer didn't occur at 24 hours, they would then have to be transferred to another bed in the same inpatient area of that hospital. And that's one of our concerns that we've expressed on the 24-hour thing, for the best patient experience to be moving them, even though they could be adequately treated with staffing and the appropriate care being provided in the observation area. At the end of 24 hours, if they were still being determined, then even under CMS 2 midnight rule, that they were still under the observation, they would have to be transferred to another unit. And that's one of our concerns. That's not in the patient's best experience.
Thank you. Any other questions? Senator Pan.
Thank you. And Senator Bell, I just want to thank you for trying to take on a very thorny issue because, I think,
coming.
well, yeah, because and I think one of the things we're all challenged with is that actually the nature of payment between outpatient and inpatient, and that somewhat, it's, one would think that'd be a very clear line, but it's not. And so is the person in, quote, inpatient or outpatient? And then on top of that is that if you're inpatient, you bill one way. If you're outpatient, you're billing another. So it's not just a matter of, physical location or the building around or something. And this, I think, challenges hospitals and physicians and nurses and everyone. So I guess so I appreciate you trying to take this on. I'm trying to figure out, I'm hearing from the different witnesses about how they're trying to struggle with this. I guess one question is that obviously from the patient's point of view, right? The patient's point of view is that, okay, I came to the hospital and I've gone through the emergency room. I may have a psychiatric condition, I may have some other condition, right? And then, I finish my, I'm going to say experience, because I don't know whether they got admitted or not. As far as the patient knows, they may not even know whether, they just know that they were there, right? And then they got sent home. And then they got and then they get, they follow up with their primary care doctor, hopefully if they have one. And they say, what happened to the hospital? And then they get a bill. And I'd actually like both sides, both to answer. So what happens? How do we help straighten things out for the patient when it comes to, they don't know whether they're admitted or not admitted, or so, at least technically. Someone guys said, they thought they got moved from one place to another, right, from one section of the building to another, and had a gurney and all that other stuff. How do we sort this out? And maybe it's too big of a conversation to have just the hearing right now, and I know the committee staff's worked very hard on this as well. So I'm just trying to figure out how we wrestle with that so that patients don't get caught in the middle. So
thanks.
perhaps maybe we can have the proponents and then the opponents of the bill try to help me out here.
Sure. Thanks for the question, Senator Pan. And I think that that's the purpose of the bill. We're trying to get at first noticing the patient. Because what we've heard from, CARA and other folks from the elderly community is they don't even know that they're in observation or an inpatient. It gets even more confusing when you're in an inpatient area in an observation bed. So I think the first step to deal with that is to provide some notice to the patient that that's the case, and that their Medicare third-party reimbursement may be impacted. Unfortunately, the bill, we can go farther in this bill. We don't directly deal with the payment issues, but we first start with notice. So I think that's kind of where you start. In terms of capacity and things of that issue, which psych patients, I know the ER docs have a bill. I think it's AB 1300 that kind of deals with that issue. We hope to make the patient experience better, get them in an inpatient as soon as possible, but we're dealing with a ghost here. These observation units technically aren't really in law. We're trying to provide some sunshine in this area. We understand that, in these areas, patients are in there for 24, 48, 72 hours, even longer. Is that good for the patient? Probably not. Depending on the psych patient, would you all like 48 hours? Not sure. We had that debate in 1269. And due to concerns from other groups, we more align this area, this observation unit, with other clinical settings because that's the closest designation to this area. So again, to your point on the notice, I think that's the first step. To Senator Roth's point, we would love to have more capacity. I think that's a bigger problem in this healthcare system. We just want to make sure that patients are cared for quickly as possible, mirror it after what we see this area to be in existing law today, and provide some sunshine. And that's where we start. We don't deal with CMS. We understand that there are other areas of the hospital that we don't touch in this bill. We don't ever want to legislate that you put a patient in the hallway, but we understand that happens now. That might be where that patient is. Again, not legislating that, not saying that's appropriate policy, but that does happen, and we're not touching on that. So there's more conversations to have. We're happy to do that, but this is a good start, we think.
Thank you, Senator Pan. This is confusing, I can understand, for the public, as you brought forth. We are under the confines of what CMS does on payment, and they clarify as to what classification of patient should be placed in as far as the payment process. This bill is not going to address any of that simply because of the fact that that is a regulatory payment process that comes from the federal government. However, there still will be observation patients that will be placed into an ICU simply because they need that higher level of care. And the patients they have the understanding that they're an observation patient, but it won't change their payment process at all, simply because that's the way CMS establishes it. And we have the 48-hour rule as to 48-hour, midnight rule as to when that patient then has to be either moved out of an observation status or to an inpatient classification for payment reasons. I know this is really confusing, and so it confuses things. So what happens is a patient can be placed into an ICU and still be an observation patient. And that happens simply because of the fact of the level of care that they need. That will still occur. And the issue then really becomes then as to when that patient is placed in an observation unit or bed, as they've called now. That was the 48-hour thing. The 2 midnight rule will be in direct conflict with the 24-hour rule that they've established in this bill. That's where there's a conflict with federal regulations versus what they have proposed here. That's one of our concerns.
So with the indulgence of the chair, is there a way we can resolve we have the 2 midnight rule at CMS, and I realize it's a billing rule, but I understand payment, to keep the hospital going is important. And is there a way to reconcile between, is there going to be an opportunity to reconcile between two on the 2 midnight versus 24-hour? Because it seems like that seems to be a particular point of contention.
Yeah, I think we're happy to talk about it. We're definitely happy to sit down and discuss this, but I think there's just a fundamental disagreement about, does SB 483 impact that? And we don't think it does. We're simply trying to get at regulating a physical location. They can right now take that patient and put them in an in an inpatient bed and still be observation. They can designate they have that opportunity for 48 hours to change that status from outpatient to inpatient. We don't touch that. We don't touch the ED. We don't touch the inpatient areas, exempted from the bill. So this is simply about regulating a physical space. I think the question for them is, well, what if we don't have enough space? Where do we put them? We can have that conversation. Again, we don't talk about the other areas of the hospital. We're simply talking about those units that are offshoots from the ER that have no staffing, no regulation. That it's a patient safety issue. So that's what we're getting at. So I don't know if they want to propose something to us in terms of that. We shouldn't be working this out now, and I apologize to the chair.
I don't think it's appropriate to be doing policy. I mean, writing language here, the only thing we are going to be voting on, the bill in hand. As amended.
Put the amendment.
With the analysis that my staff has done, the time that we've put in. If this is something that you're interested in doing outside of this committee, before appropriations, in the next committee, but the only thing I'm prepared to vote on today is this bill. I believe Senator Nielsen had a question, and Senator Roth, unless you're done, or
May I ask one?
Yeah, sure, by all means.
Thank you, Chair. So I understand what you're saying. So I'm hearing two different things about, because you're in terms of space, because what I'm hearing is that from the bill supporters that you want to try to regulate a particular space, but what I'm also hearing from the opponents in description of the payment is that, well, you could have an inpatient unit or even the ICU, and you can have a patient in a bed or in a space that is basically being called observation. And I don't know whether at some point in time you hit the 2 midnight or whatever else, it now becomes, now you're admitted and you're not even physically moving or not. I mean, are we talking about simply some physical space that is not at all? So if you have a patient who's in the ICU, which who's under observation, then this bill, would it apply or not apply to that? So it only applies to some physical space that's purely for observation. That's not an emergency room. It's not actually a floor. I mean, physically the floor, physically an ICU. It's that's what you're talking about. So if someone's put an observation on the floor and they're classified observation, or in the ICU classified observation, this bill would not apply.
We took language in the bill, and I think it's in print now, that said observation services shall apply in an observation unit, and we define what the unit is. So we've made that clear in the bill.
So,
we can ask the opponent.
Yeah, the state of California doesn't recognize observation unit. We don't have a classification for that. There is where the conflict is. We have patients who are in observation, and we have the bill that deals with observation units, but there isn't a classification and license. Like, you have ICU beds, you have this department, there isn't observation.
Okay, I believe Senator Nielsen had a question, then we're going to go back to Senator Roth. Question, comment?
Well, I'm probably going from mixed up to confused. The definition of observation area or unit seems to be very important. And am I correct that we have not settled that issue here, at least as far as the hospital folks have been concerned? In the amendment
That is correct.
The issue is somewhat telling to me about the regulation that you've just spoken to, that's just been spoken to. Now, is that of satisfaction to what's proposed in the amendment? I haven't seen any amended language.
The amendments do not address our concerns. We still feel that there is still the conflict that exists, and I think it'll be a difference between the two.
Okay, and have we taken, have amendments been taken to the bill? I might have missed something.
It's in the analysis. There's not a mock-up, but it is an analysis.
Yes,
it's described in page 5 of 7.
Okay, all right. And that says in a setting outside an inpatient unit is not a part of the emergency department. Is that what we're talking about?
The one proposed amendment. Yes, that's correct.
All right.
Any other questions? Senator Roth.
Thank you, Mr. Chair. So observation unit is a setting outside of an inpatient unit. And then our analysis states that this requires observation services et cetera, to comply with the same staffing standards, including licensed nurse-to-patient ratios as supplemental emergency services. What does that mean, and is that a concern for anybody, and how are the staffing ratios set? I guess that's 3 questions in one, sorry.
I'll let my board members speak more to this, but what we're trying to say in the bill is this. Already existing law right now, what hospitals do is you can have an observation patient in an observation bed in an inpatient area, not part of the bill. So if you're in the ICU, the appropriate ratio applies. Right. If you're in med-surg, appropriate ratio applies. So we dealt with this 3 years ago, and we all agree, I believe, at this table, unless you guys disagree, that that currently happens. Right. We're fine with that. What we wanted to make clear in this bill, that if you're in the ER under observation, this bill also doesn't apply. Because ER is technically, for, I think, payment purposes and for reimbursement, it's technically considered an outpatient area, but it's not really, it doesn't really function as such. So we wanted to exempt the ER out of the bill. Totally appropriate.
Staff in there usually.
And there's staff. What we're trying to say in this bill is if you're not in the ER or an observation in an inpatient bed and you're in a unit, a physical location that's off from the ER, and these, you can say they exist or don't exist, they're in existence now. They're called clinical decision areas. They're called rapid observation. Whether they exist in law or not, they're happening. They are being built as a part of the hospital structure currently. And what we know about those physical locations, they are treated as outpatient areas. That means no staffing. That means no services that are applied. So what we're saying is, okay, if we could apply an appropriate staffing ratio, what would be applicable? Since it's an offshoot from the ER, we said the ER ratio should apply. So that's what that means.
Is that a fairly high staffing ratio, staffing to patient ratio, as opposed to?
The ER is a 1-to-4 ratio.
Is there any concern over the staffing ratio?
I don't think so.
I mean, the proponents have concern, obviously.
So who are you addressing the question to?
The opposition,
Please.
Mr. Chair.
That issue we're not concerned about. Our concern is that if we cannot utilize those beds to their fullest extent recognized by CMS, which is now 2-midnight rule, we may start to have shortages because we now dedicate beds to an observation, and that patient can only be in there for 24 hours. But they need 36 hours for the assessment that, which under CMS is allowed under the billing process and what they qualify as patients. Now we have to move that patient to an inpatient where we may not have a bed. Where do we place that patient? Now we've taken those beds and classified them as observation patients.
Or the emergency room.
That's right. So if we start beginning to have beds that have been licensed as med-surg and they're observation beds now, observation unit beds, and they can only be there for 24 hours, we can't utilize those beds to their fullest extent, even as recognized by CMS.
Well, what do you do then when you have you have no beds you have no inpatient beds left because you're 100% occupancy and your emergency room is spilling people out the door and you have somebody that you don't feel comfortable sending home? Do you stick them in an ambulance and send them somewhere? What do you do?
No, we try to facilitate the best we can with the beds we have. But those patients are in licensed med-surg beds as such, and that's where they are now.
Do different things.
Thank you, Mr. Chair.
Thank you. I believe Senator Pan, one more comment?
I think.
So actually,
The reality is, if we had sorry.
Well, I think she was going to respond to my question, Mr. Chair.
Sure.
With your permission, sir.
So the reality is, if there is no bed in the hospital and there is no bed in a clinical decision area, then there will be movement and there will be patients that will be discharged before they should have gone home. That's what happens now.
Thank you, Mr. Chair. Thank you, Dr. Pan.
okay, so what I am hearing is that there's these observation beds. I heard that, it sounds like you acknowledge they exist, that the units, and how are they licensed, these beds?
There is no license. There's no category in Title 22 at the present time. They're all med-surg beds, that they're beds in the hospital.
Have to establish the rules.
So they are licensed as med-surg beds?
Yes.
Okay. All right. I guess my brief comment is that, I mean, I think there's certainly more work to do, but I also think there's a real problem that we need to resolve. And so I do think, I hope that people, and we're not going to do it, right, but I think there's definitely more work to move forward, but I appreciate the author trying to address this issue.
Any other, yes, Senator Nielsen.
Mr. Chairman, let me just add, and I would follow on Senator Pan's observation, that I think it's not settled here yet. I think the authors made a very good faith effort, but I think that there is still more work to be done. That said, I'm just going to abstain right now and watch the future developments, because I'm troubled by some parts of this, but there's been a good faith effort, but I think there's more work that needs to be done as the bill progresses.
Thank you. Any other, seeing no other questions or comments, what's the pleasure of the committee? Seems like there's still a lot of, we have a motion to move the bill by Senator Mitchell. Would you like to close?
Yeah, thank you. We did make an amendment clarifying emergency rooms are not considered an observation unit, so we did clarify that, and we're continuing to work with the concerns of the hospital association. I want to point out that just the discussion that we had indicates one thing to me, and that we need to define some things. We need to set some parameters. For me, it's pretty obvious from the system we have now that there is no definition and rules and how they operate these, whatever they call them, netherworlds or observation units or whatever you want to call them. Everybody calls them different things. So we need to establish some rules. And we also need to monitor and get some data on these things. That's what the other thing the bill did. We didn't really talk about that. If we don't do that, what we're going to have is a continuation of what I consider to be disparate healthcare services for people in California. And we need to establish some evaluation and some rules for this. So I urge and I vote. I think this, I'll continue to work with the opposition, I promise you that. But I also think we need to deal with this question. There are literally hundreds of people that are affected by this, and their basic health care is at stake. So we don't want to have a disparate healthcare system where people are parked in observation units. I urge and I vote. Thank you.
Okay, we hear a commitment from the author to continue work on the outstanding issues. This item number 12, SB 483, do pass as a minute. Thanks for being on time, Senator Hall. Call the member, do pass as a minute to appropriations. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Aye. Hall, aye. Mitchell.
Aye.
Mitchell, aye. Monning. Nielsen. Pan. Aye. Pan, aye. Roth. Wolk.
That currently has 4. We're going to place that bill on call, Senator.
Thank you, Senator.
Thank you, Senator.
Thank you. Senator Wachowski, you're up next, unless you want to wait.